السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم in case of the week 14 on our channel 4D Passion. This is a case referred to my center for a third trimester anomaly scan. The case was at 31 weeks 6 days gestational age. At first glance you will notice that at abdominal circumference view the stomach is in situ within the abdomen. But here is a diaphragmatic defect, and the diaphragmatic defect is seen admitting bowel loops into the thorax, and there is a dilated renal pelvis of the left kidney of the fetus. Here is again the fourth chamber view of the fetus with the heart markedly displaced to the right side, with a left-sided diaphragmatic hernia admitting small bowel loops and a small left lung, small right lung, sorry. The heart also shows slightly compressed right, the left ventricle and left atrium. And here is my pelvic tasia of the fetal left kidney. On the multiplanar 3D rendering, you will notice the better depiction of the diaphragmatic copula and the diaphragmatic defect of about 5 centimeters. And here is on multiplanar imaging at coronal view, you will notice that the diaphragmatic defect is apparently right here with the herniated bowel content. Again, the hernial contents. This may be a partial protrusion of the stomach. Again, the heart and and you will notice also here that there is a part of the left lobe of the liver herniated. You can notice it right here with the portal radicals. Again, right here. Here we will notice the difference in echogenicity between the liver and the left lung, which is more echogenic. And you will also notice the transverse lie of the part of the fetal stomach that is herniated, transiently herniated into the thorax. So the findings are a left-sided diaphragmatic hernia with a diaphragmatic defect, seen admitting multiple small bowel loops as well as part of left lobe of liver, markedly displacing the heart to the right side, abutting the right chest wall with dextroposition and dextroversion of the heart, and slightly narrowed left ventricle and left atrium from mass effect of the herniated contents. And we will calculate later the lung to head ratio and lung to head area and diameter method, and the observed to expected lung to head ratio. Here is a 3D with VCI is additive in delineating the diaphragm and diaphragmatic defect. So the diagnosis is right-sided diaphragmatic hernia, which is a relatively common anomaly. 40% of cases are syndromic, 5 to 15% chromosomal anomalies, mainly trisomies 18 and 21, and 25 to 30% of non-chromosomal syndromes. The types of diaphragmatic hernia are either pogdalic, which is left posterolateral and constituting about 75 to 85% of cases, Morgani hernia, which is a right hemidiaphragm with constituting 10 to 15% of all diaphragmatic hernias, and bilateral in 3 to 4% of cases. Here is some syndromes that are associated with diaphragmatic hernia, such as Pallister-Killian syndrome, French syndrome, Goroshny-Posh syndrome, and Simpson-Globey syndrome, Bickwith-Widman syndrome, and microphthalmia with linear skin defects, Gold syndrome, cranio-frontonasal syndrome, and Pagdo syndrome and Dense-Trash syndrome. Embryologically, congenital diaphragmatic hernias originate if normal closure of primary pleuroperitoneal channels doesn't occur. Prognostically, the main problem of a congenital diaphragmatic hernia is not the defect itself, but rather the occurrence and degree of pulmonary damage. This consists of severe alveolar hypoplasia induced by the long-term compression of the lung exerted by the migrated abdominal viscera. After birth, the onset of pulmonary hypertension can further complicate the situation. The association of pulmonary hypoplasia with pulmonary hypertension represents the main determinant of this in neonates with non-syndromic congenital diaphragmatic hernia. In left-sided hernias, the stomach is found in the thorax in most cases, about 90% of cases. In a minority of cases, a left diaphragmatic hernia, only some iliac lobes and or the left hepatic lobe migrate into thorax, like in our case, or even the spleen sometimes. The right-sided diaphragmatic hernias is more difficult to diagnose. The main signs include the heart displacement to the left side, liver up in the thorax. This is difficult to evaluate due to similar lung and liver echogenicity. In my own experience, a very important sign is the presence of hepatic veins in thorax at level of forward chamber view in order to diagnose the right-sided diaphragmatic hernia. A new sign for the diagnosis of right-sided diaphragmatic hernia is the transverse position of fetal stomach within the abdomen. Even though embryologically the diaphragmatic defect occurs at 12 weeks of gestation, the moment at which the viscera herniate is extremely variable and ranges from early second trimester to the first hours of life. In the latter instance, it is the first braces that determine the migration of the viscera. And I know that a case that was with one of my colleagues, the diaphragmatic hernia never appeared during obstetric ultrasound despite careful ultrasound and 4D for the case, and only apparent after birth. Here is an image to show the sign of transverse lie of the stomach within the abdomen in case of right-sided diaphragmatic hernia. The predictors of outcome include lung size, lung to head ratio, and observed to expected lung to head ratio, or observed to expected total lung volume, which is detected by MRI, and liver position, which is either liver up or down, and liver to thoracic area ratio, which and the volume of liver in thorax, which is done by MRI, and liver to thorax volume ratio by MRI also. Stomach position and 3 defect size by MRI. Here on ultrasound, we will diagnose it by the lung to head ratio, which can either be by the diameter method, which is less accurate than the area trace method. This is done for the lung contralateral to the diaphragmatic defect, and better when this lung is close to the transducer. Here is an example in our case how to measure the diameter methods and the area methods in order to get the lung to head ratio and observe to expected lung to head ratio. On perinatology, there is a chart for this, and you will enter just the head circumference of the baby in millimeters and the diaphragmatic defect in millimeters, the area methods in the area traced by millimeter square, and the length of 2 dimensions in diameter method for detection of lung to head ratio, and the gestational age of the fetus by weeks and days, and then you calculate. When you calculate, you will get the lung to head ratio. If it is 1 or less, the prognosis is poor. The prognosis is poorer still if the liver is in the thorax, liver up. Such patients may be candidate for prenatal intervention, such as the fetal procedures that we will gonna talk about it shortly. If the lung to head ratio is between 1 to 1.4, extracorporeal membranous oxygenation (ECMO) is often needed. If the lung to head ratio is greater than 1.4, the prognosis is better. You will also get the lung to head ratio observed to expected lung to head ratio. That are in some studies found that 100% survival in patients with isolated congenital diaphragmatic hernia when the observed to expected lung to head ratio on ultrasound was greater than 45%, whereas there are few survivors when the ratio was less than 25%. Lung head ratio changes over gestation as lung area grows more rapidly than the head circumference, and the observed to expected expected lung head ratio corrects for gestational age, and this is so it is better determinant of prognosis than the lung to head ratio. Observed to expected lung to head ratio is currently the best ultrasound marker. Another newly detected marker, that is the quantitative lung index, can also be used, but still under clinical studies. Here is the prognosis from severe to moderate to mild according to lung to head ratio and the observed to expected lung to head ratio and the position of the liver, whether up or down. And there's some syndromes that are associated with congenital diaphragmatic hernia, including as well corneal helangiectasia and Joshua-Levin syndrome. The prognosis in isolated cases can be grouped into poor, moderate, and severe. As aforementioned, observed to expected lung head ratio is the most important parameter at current. Prognosis is poorer in case of liver up. Prognosis is poorer in syndromic cases. Prognosis is poorer in cases of marked displacement of the heart to the contralateral chest wall, like in our case. Survival rates ranges between 30 and 80%, with a median of 50 to 60% for a left-sided congenital diaphragmatic hernia. Fairly frequently, but less important, long-term sequelae include gross retardation, gastroesophageal reflux, chronic lung disease, and rarely oxygen requirement. Management of poor prognosis cases. A new approach consists of the creation of an iatrogenic obstruction of the high airways achieved with the insertion of a balloon catheter in the fetal trachea. The balloon is left in place for several weeks, during which it stimulates alveolar growth, and it eventually removed just prior to delivery. The procedure, which was originally performed with a surgical approach, is currently done under fetoscopic guidance, which reduces invasiveness, riskiness, and costs. The name of the procedure is fetal endoscopic tracheal occlusion, which denotes the limited invasiveness of the endoscopic approach. The latest update on the result of this procedure are the following. On the basis of stratified data from the antenatal congenital diaphragmatic hernia registry, fetal seems to increase survival in severe cases with left-sided congenital diaphragmatic hernia from 24.1% to 49.1%, and with a right-sided congenital diaphragmatic hernia from 0% to 35.3%. The strongest predictor of survival were the observed to expected lung to head ratio prior to the procedure and gestational age at delivery. Differential diagnosis. For left-sided congenital diaphragmatic hernia, the differential diagnosis includes the macrocystic subtype of congenital cystic adenomatoid malformation of the lung, because of the stomach might at least theoretically resembles the dominant cyst in macrocystic type. The right-sided congenital diaphragmatic hernia should be differentiated from the solid microcystic variant of congenital adenomatoid malformation of the lung and pulmonary sequestration. The echogenicity of the intrathoracic liver and intestine should be differentiated from the highly hyperechoic congenital cystic adenomatoid malformation, although the difference in brightness is usually significant. Here is an examples of left-sided diaphragmatic hernias. With the macrocystic, this is an example of CCAM. You will see the macrocystic variant with a dominant cyst right here, and here is the microcystic type, which resembles to some extent the liver, but an important sign to differentiate also includes the presence of hepatic veins on colored Doppler. So the take-home message, not only we can diagnose congenital diaphragmatic hernia antenatally by ultrasound, but also we can prognosticate it. The observed or expected lung head ratio is the most accepted sonographic parameter at current, and it is available on perinatology site. Right-sided diaphragmatic hernia is more challenging in diagnosis, but heart displacement to the left and the hepatic veins at thorax level of four-chamber view are reliable signs. A new sign is a transverse lie of stomach within the abdomen. Always get a good cross-section of the thorax at level of four-chamber view with complete rib on each side to avoid false diagnosis of congenital diaphragmatic hernia that I can see in some cases misdiagnosed by other physicians. Always use color Doppler to verify vessels. 3D sagittal, parasagittal, and coronal views, multiplanar and TUI with VCI is additive in viewing the diaphragmatic defect and the herniated contents. Diaphragmatic hernia is an evolving process that can be diagnosed as early as 12 weeks of gestation, but also visceral herniation may not appear till early in neonatal life until the neonate braces his or her first braces. A careful examination should be carried by an expert to exclude syndromic cases that are the issue in 40% of congenital diaphragmatic hernia, and timely delivery in a tertiary center is always recommended. Kind regards and see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Amr Farouk.